This is Kate Wakelin from Neuroendocrine Cancer Australia, and it's Friday again. It's Friday the 9th of October, so welcome to Facebook Friday. Just before we get going, I just wanted to acknowledge the traditional owners of the land that I'm broadcasting to you from, which is the land of the Wurundjeri people of the Kulin Nation, and I would like to pay my respects to elders past, present and emerging. One of the things I really love about where I live is being able to go for a run along the Yarra River, which is in the Woi-Wurrung language is called the Birrarung. So I know that you are joining me from all corners of Australia and even beyond via Facebook Live and also via our YouTube station. So welcome to wherever you're joining us from. So I'm not going to talk a lot about COVID today because there's probably not a lot of update for me to give you, apart from the fact that we've seen some marked decreases in the number of cancers that have been diagnosed across the community, and we think that's due to COVID and people delaying having tests and screening and that sort of thing. So living with a neuroendocrine tumour doesn't absolve you from needing to have the rest of your health looked at. So if you've been, if you've got a skin spot or a mole that you've been sort of sitting on and thinking, oh, well, I'll get round to that, but I don't want to go to see my doctor, or if you may need to do your fecal occult blood test for bowel cancer, or you've got other, like your mammogram or other screening, or any health concerns, this is just a reminder to you to don't forget to look after yourself. We're actually, as a health community, as a cancer community, we're actually expecting that we'll have an increase in cancer diagnoses down the track, and I guess our worry is that maybe those diagnoses will be happening, there'll be a delay in some of those diagnoses. So we're really wanting to make sure that people are going to see their doctor and having their health checks. And it's also a chance for you to remind your family and your friends, don't forget about the rest of your health, even though that, a lot of people are living with some very direct impacts from coronavirus, but cancer won't wait. So and I know that you guys know that as well as anybody. So that's just the only thing that I would probably say about coronavirus. So today we don't have a guest expert. I'm it, and you get to, I guess, grill me, and I'll be giving you some general information about chemotherapy. Just before I launch too much into all of that content, I just wanted to remind everybody that this is general. So every net, like every unicorn, is unique, and every person will have slight differences in the way that their team approach their cancer and the way that they're treated. Just because I have said something on here doesn't necessarily mean that your team has got it wrong. It probably just means that you've got a slightly different type of tumour, or it's behaving in a different way. So always take what I say with a big grain of salt, and talk to your treatment team about your own situation. So that's just probably my important disclaimers, and I can see a few people have drifted in, which is really lovely to see you all. So thank you for saying hello and happy Friday. So I wanted to just go back to some basic biology when I'm talking about how chemotherapy works. So chemotherapy is really, in this context, is talking about drugs that are toxic to the DNA in cells. So just again, going back to some really basic biology, your whole body is made up of cells, and the cells are like the building block of your body. You can see cells in fruit. So if you cut an orange open, and you can see all of those individual tiny little pockets of fluid, they're actually cells. So we've got cells in our body. They're not filled with orange juice and other delicious things. They're filled with body. There's lots of different parts of our bodies that the cells are designed to do different functions depending on where they are. And probably, as you all know, we've got neuroendocrine cells throughout our bodies that most of us aren't even aware of because they don't give us many troubles. But when you get a tumour that's grown out of those cells, you get a neuroendocrine tumour, and that's where we become very much more interested in this whole system. So back to chemotherapy. Chemotherapy actually damages the DNA, which is the genetic material in cells. And it works particularly effective when cells are making new cells really quickly or really rapidly. So in cancer, we know that's happening at a much faster rate of knots than a normal cell in your body. And with neuroendocrine tumours, that's why we get too many of them, and they eventually form a lump and they can grow and spread around the body. So that's the key concern that we're wanting to address with these treatments. Chemotherapy targets cells that are rapidly dividing and rapidly making new ones. It targets cells that it works better on cells that are doing that quickly, and that's where grade often comes in. So grade is talking about how quickly those cells are dividing and making new ones, and the more quickly they're doing that, usually the more sensitive to chemotherapy these cells will be. And so we'll find that people with a really high-grade neuroendocrine tumour or neuroendocrine carcinoma, which is another category on top of neuroendocrine tumours. So we've got grade 1, grade 2, grade 3A, and they are all neuroendocrine tumours, sort of ranging from the very, very slow growing right up to ones that are making new tumour cells much more quickly. And then we've got grade 3B, which is neuroendocrine carcinoma. So there's actually another video that I did, it was actually a few months ago now, but I'll put a link to that in the notes. And I know there was some conversations about grades and stages in our group this week. I'll refer you back to that video, and what I'd love you to do is tell me if that's clear, and if there are more questions that are coming out of that, I'm really happy to do a follow-up video about grades and stages, because it is really complex. So the higher the grade, the more quickly the tumour cells are reproducing themselves, and the more sensitive that they will be to chemotherapy. So chemotherapy only targets cells when they're actively dividing. So what it will do is it will damage the DNA in the cell, and that does two things. It can kill the cells, and that's often what we think of when we think of chemotherapy. But the other thing that chemotherapy can do with cancer cells that we want to happen is that it can actually make it more sensitive to radiation. So sometimes we'll give chemotherapy, not so much because we're expecting the chemotherapy will shrink the tumour directly, but you're going to have some radiation treatment coming up, and we want to make those tumour cells as sensitive as possible to the damage that we give by with the radiation. So a lot of you will be, and I know this has been discussed a lot in the Facebook group, people on CAPTEM, and I'll talk a bit more about CAPTEM, but it's often used leading up to a radiation treatment called PRRT, or sometimes that's called lutate therapy, which is a special radiation which is given in the bloodstream. I'm not going to talk much about that today because that's another topic for another day, but we're actually giving that treatment because it'll sensitize. We expect and we hope that it will sensitize the tumours and make them more fragile and therefore more likely to fall over when we give them that PRRT treatment. So how is chemotherapy given? So in the media and on movies and things, often you'll see people having chemotherapy with a drip through the vein, and that's probably that's a really common perception. But a lot of you with neuroendocrine tumours will be having chemotherapy tablets. But we also can give chemotherapy in the form of skin creams. We can put it directly into the abdominal cavity. We can inject it directly into the bloodstream, into an area of tumour, which some people will have had. And sometimes we'll even put it into the spinal cord. So there's lots of ways that chemotherapy is given. It's not just given with a drip, but commonly with neuroendocrine tumours, as I said, tablets are a way that they're given. So I wanted to just go over very briefly some of the common regimes that we see in neuroendocrine tumours, and the one that we probably hear discussed the most is CAPTEM. So with all of the chemotherapy regimes, they're kind of given a nickname by the doctors and by the people who are using them. So CAPTEM is a combination of two drugs, which is capecitabine and temozolomide. So they're given on different days and different dosages. And one of the things that we see in our support groups is that people will find there's differences between what you're having with CAPTEM and what I'm having with CAPTEM. The dosage, the individual nuances of that regime. And that's a really important thing for us to keep in mind about chemotherapy, is that it is very individual. So different people will get different side effects. Their bone marrow will cope differently. There's sometimes it's about kidney function or liver function, but the dosage won't be the same from person to person. Also, if I'm 6'4", I'll have a higher dose, and a burly kind of build, I'll have a bigger dose of chemotherapy to if I'm really much more petite. So it's given according to your body mass as well as all of those other individual factors. So there's a limited extent to which we can really compare from person to person with this. So another couple of the more common regimes that we hear bandied around in neuroendocrine tumour land is FOLFOX and FOLFIRI. Now, FOLFOX is a combination of a couple of drugs, but 5-FU, which is actually the IV, the intravenous version of capecitabine. So it's the same drug given through a drip, and oxaliplatin is the other drug that is given in that regime. FOLFIRI is very similar. It's 5-FU and a drug called irinotecan. They're drugs so those two regimes, FOLFOX and FOLFIRI, and sometimes they even combine those three drugs together, so you get FOLFOXIRI, sometimes people will call it, which is oxaliplatin, 5-FU, oxaliplatin, and irinotecan. So they're all given via a drip, usually in a day chemotherapy centre or in a hospital. They'll often give those regimes when the cells are dividing a little bit more rapidly than if it's a very, very low grade tumour. But there's, again, lots and lots of individual differences there. But it's, I guess, just worth knowing that those terms like FOLFOX, FOLFIRI, CABTEM, they're like the nickname, and they combine various bits of the names of the drugs. So you don't need to worry too much about remembering the really long names, but the regimes, they're handy to have in your records, because it might be that later down the track someone asks you, a doctor asks you, or you need to know which particular regime of chemotherapy you're on. So those nicknames can be really useful. They're just a little bit easier to say than the big fat drug names that they're called. The other one that I just wanted to mention is a regime called carboetoposide or carboplatin etoposide. It's a combination of those two drugs, and that's given when tumours are more aggressive again. So when they're quite rapidly dividing, and we're thinking probably the grade 3s. Sometimes people in the higher grade 2s will also have carboplatin and etoposide as a regime, but it's often given because the cells that are rapidly reproducing are quite sensitive to those two drugs. So you'll see some people in our Facebook group and our community who are on that treatment as well. There's lots of other different sorts of chemotherapy. There's over 100 different chemotherapy drugs. So different situations will call for different combinations. Sometimes when CABTEM hasn't worked, they'll try some FOLFOX. If FOLFOX hasn't worked or stops working, they might try some FOLFIRI. Sometimes, you might have some carboplatin and etoposide. It's a very personalised, I'm not going to say the word journey, but it is a very personalised treatment. And so it's really difficult to make comparisons from person to person. The other thing that I would just say about what regime is used in which person, in most cancers, we really rely on the data from clinical trials to guide the chemotherapy and other treatments for the particular type of cancer. That's easier in really common cancers, because if you think about it, in Australia there are thousands and thousands and thousands of women out there with breast cancer. So we can do the same treatment on women with a very similar type of cancer and get really solid impressions about what most of those patients are going to do, how most of them are going to respond, and what the side effects will be. When it's a less common cancer, it's a lot more challenging to get really good quality data from clinical trials. Recruiting to clinical trials is more challenging. It's hard to get enough people to really know that you're comparing apples with apples. So sometimes that will lead to variation in the drugs that are used, because there is a bit of artistry and a bit of guesswork, unfortunately, with these treatments. And sometimes it's why don't we try this? We've seen it work in other sorts of cancers that might have some similarities. It's worth a try. We know what the side effects are. It seems that it's worth the try. So I've seen in the Facebook group sometimes this, well, why is this person on this treatment and why is this person not on? I look the same. Why am I not on that treatment? And that's another thing that sometimes we don't have the clinical trial data to really support it in a very solid way. But if this person's tumours are on the grow or on the move, sometimes it's worth a look at that. The other thing that can happen is that you might be invited to a clinical trial, and clinical trials is another topic for another day, so I'm not going to go into that in too much detail, but we're running clinical trials all the time into neuroendocrine cancer. One of the trials that we've looked at specifically related to chemotherapy was the Control Nets study, and I know there's actually quite a lot of people who were in our Facebook group who were part of that trial, and that gave us some really important data about the use of chemotherapy in the lead up to PRRT. So we're doing trials all the time. It's just worth talking with your treatment team about whether there are any trials on the horizon that might be useful for you. So I'm just wanting to not take up all of your afternoon, although a couple of people said please do, but I am assured that you've got other things that are really important to be getting on with your day. And I did want to talk about side effects, because this is a thing. We can establish that a treatment might be helping to reduce tumour size, or slow down that growth of the tumours around the body, but if it's making you feel awful, then that's not great. That's not a great outcome. So chemotherapy targets, I'm just going to go back to my basic biology. Chemotherapy targets cells that are dividing rapidly. There are normal parts of our body that's their job to do. So if you think about, for example, the cells that line your mouth, they're reproducing all the time. Every day you essentially are growing a new layer of inside of your mouth. It's really amazing and really clever. Other parts of your body that are replacing cells every day is your bone marrow. So that's building new blood cells all the time. We're getting new blood cells in. Your body's recycling the ones that are worn out and ready to retire. So some parts of your body will be more susceptible to side effects because of the chemotherapy, because they're replacing their cells more quickly and they're more susceptible to damage. So just going back, a lot of people do experience mouth ulcers with chemotherapy. Now there's some really good stuff that we can do for that, and one of the first things that we can do is prevention. It's much better to prevent than to cure. So oral hygiene and keeping your mouth really clean is really important. Avoiding mouth trauma. So if you're on a chemotherapy and we think that you might be more at risk of mouth ulcers, using a soft toothbrush and avoiding, when you're brushing your teeth, avoiding jamming that toothbrush too vigorously around, but brush your teeth gently. Rinsing your mouth or brushing your teeth gently after every meal or after every snack, just to keep that bacteria level down, so that if there is a little bit of a damaged area in your mouth, that's less likely to get infected and get ulcerated. Also, sometimes avoiding spicy food like really hot chili can be helpful in just and crunchy food. Like, I don't know if anybody else has eaten a corn chip and found that they've abraded their mouth from a corn chip or a crunchy lolly. So just protecting your mouth from trauma, both physical trauma but also chemical trauma in the form of chili. So maybe holding off on the spices, being gentle with brushing, keeping your mouth really clean is a great place to start. If you do get a mouth ulcer, again, keeping it fastidiously clean is important. Make sure you tell your treatment team. So next time you're going for your appointment, if you've got a mouth ulcer or two, then make sure you tell them so that they can have a look. There's a really fantastic ointment that you can get over the counter at pharmacies in Australia called Kenalog in Orabase. That's a really fantastic one that, as a chemo nurse, we were writing that on every sticky note and giving it to every patient, saying that's probably the first thing that I would use. I would recommend for mouth ulcers caused by chemotherapy. So it's called Kenalog in Orabase, and I'll make sure I put that in the notes. As I mentioned before, one of the other parts of your body that's really reproducing quickly or making new cells quickly is in your bone marrow. So when you're on chemotherapy, you will be having regular blood tests, which really checks if your bone marrow is coping with the treatment. You can also, there are other treatments that also impact on bone marrow. So PRRT can, and that's the other treatment where you'll be having, one of the other treatments where you'll be having regular blood tests. If your blood cells are a bit low, they will recover, they will generally recover, but sometimes that can mean there'll be a delay. So they might just hold off. If you're having, for example, Folfox, which is every 2 weeks, if they take your blood, if they check your blood just before your chemotherapy is due and they find actually the levels are a bit low, they'll often delay that, and people really feel very worried when that happens. I wanted to let you know that that's actually really common for that to happen, and it doesn't mean there's a problem. It doesn't mean that the tumour is going to be starting to really march around your body. It's really important that we don't make you sicker with the treatment than you would be with the disease. So we need to make sure it's safe. And if you don't have enough of blood cells, you can have things like anemia, so being very, very low in hemoglobin, which can make you feel so tired and short of breath. You can be low in neutrophils, which are like your body's immune system, so you could be more prone to getting a really nasty infection. You might become low in platelets, which is really vital for your body's ability to clot the blood. So these things are important from a safety point of view. So don't panic if your blood levels are too low for you to have your treatment that week. They will probably just delay. The other thing they might do is reduce the dose. And again, you don't need to panic about that. The dosage is very individual, and everyone's response to treatment will be individual. So what will be a reasonable dose and reasonably tolerated dose for one person may not be for another person, and you might just have bone marrow that's just going to be a little bit more susceptible to that damage to its DNA, and we need to keep you safe whilst doing all we can to control those tumours. So that's also the reason why people who are having chemotherapy can be considered to be immunocompromised, so or immunosuppressed, because the bone marrow may not be producing as much of those blood cells as it would normally do. So you need to protect yourselves from things like coughs and colds. And look, we're all hyper aware of that at the moment because of COVID, but actually this is reality for a lot of people on chemotherapy anyway. So the importance of washing your hands, not touching your nose and your mouth, not hanging around people who are sniffling, and being particularly careful in places like public transport that in the winter season. And again, COVID, the levels of cold and flu in Australia have gone dramatically down, which is really interesting because we've all been so careful about not catching COVID. But maybe when life gets back to normal a little bit more, that's going to become more important again. So I've talked about the mouth. I'm just looking through my list I've got a bit of a checklist because there was a bit to cover today, so apologies for looking down every now and again. This skin is, so we've talked about the skin on the inside of your mouth. The skin on your rest of your body is also, making new skin cells all the time. So a lot of people find that their skin feels very dry when they're on chemotherapy. So it's not, I think sometimes there's a gendered thing with moisturizers that we think, oh, well, if you're female, then, okay, go ahead and get some moisturizer. But if you're a bloke, that's really important too. We do not want you to have cracks and rough areas and holes in your skin where the bugs can get in and make an infection. So if you've got dry skin, regardless of who you are, what your gender is, make sure you're using a moisturizer. And just Sorbeline from the supermarket's often a really great place to start, especially if it hasn't got your fragrances and alcohol and other magic goodies in there. So it doesn't have to be expensive. Sorbeline can be really, really effective. The other really common side effect of chemotherapy is, and actually all cancer treatment and just cancer itself, there's two, and the first one is fatigue, which can be really disabling, and chemo brain. And we used to call it chemo brain. I've talked about this in another video. I'll try and find a link for that. We used to think it was actually just because of chemotherapy, but now we think more that it's about cancer and the chemicals that cancer is actually producing in our bodies. But a lot of people find that they are vague, they have trouble finding words, they have trouble remembering what they were going to do next. You become much more reliant on having a diary and a list of things to do. And fatigue is the sort of like the other side to that. So just, and again, a lot of people think, oh, well, look, I've been tired before, I've had a tired day before, but the fatigue with chemotherapy and indeed with cancer can be another level entirely. Just in regards to both chemo brain and fatigue, we've found that exercise, which is a bit ironic, it feels a bit ironic, and I know we did an exercise in Net's session several months ago now. This is just going to be a big bunch of links in my notes, but I'll put a link in there. But we've actually shown that doing some exercise can help with both of those things, with fatigue, but also that chemo brain. So the solution is not always to go to bed, although sometimes that's the only thing it's the only thing you can do, and so you just do what you're going to do to get through that day. But doing some regular exercise, and it actually needs to be of a fairly moderate intensity, so it's not just going for a stroll, it's actually going, walking, or even breaking out into a little bit of a jog to get your heart rate going and get yourself breathing a little bit harder. Lifting weights is another really good thing, and it doesn't have to be at the gym, because lots of us aren't going to the gym at the moment, but it might just be some tin cans and a couple of shopping bags and raising your arms above your head, if just to get your heart rate going and getting that metabolism going, and that can really help with fatigue. You can also receive guidance from an accredited exercise physiologist or a physiotherapist about structuring your exercise in a way that's going to not wipe you out, because I guess that's the risk when you're launching into some more exercises, that sometimes you can overdo it and often you don't realise till the next day. So it's a bit of trial and error, and a lot of people do need a bit of guidance, so an exercise physiologist or a physiotherapist are really great with that. The other thing is that sometimes if you've got carcinoid syndrome, people can feel a little bit worried about doing exercise and stimulating a carcinoid crisis. What we know about that is that it's very, very rare for that to happen, so it's very low risk. But if you're really symptomatic from carcinoid syndrome, and again, you need some more guidance, then an exercise physiologist, they can actually monitor your blood pressure throughout exercise. So it's a great way of establishing what the ground rules will be for you, so that you can safely go and be confident about exercising, out and about in your own community. So I've talked about skin, I've talked about fatigue, I've talked about chemo brain, and blood. I've talked about mouth. I need to talk about nausea, which is probably the most common thing when you're looking at movies and someone's on chemo. Everyone has their head in a bucket. Now, it's actually not as common as it's portrayed, and a lot of people feel really worried about going onto chemo because they feel like it's going to make them nauseous. A couple of things I would say about nausea. It's a little bit like pain in that the body is very good at becoming accustomed to transmitting signals of nausea. That means it's really important for us to control it in a really proactive way. So we do not want people to just be thinking, oh, I'm on chemo, so I'm feeling nauseous, I've just got to put up with it. Please don't just put up with it. It's really important that we manage that, because if your body gets into a bit of a habit of feeling nauseated, it may well just continue to give you those signals. And I've got patients who, I've worked with for years in the day chemo centre where I used to work. They couldn't even drive past the day chemo centre without sort of starting to feel queasy. So it's like the body starts to actually really anticipate what's going to cause the nausea, and it can be really distressing long term. So there's some really fantastic medications that we use for nausea. Like everything, every medication has a side effect, so we've got to talk about that too. It's a individualized system, but if one drug doesn't work for you, there's other options. There's lots of different types of drugs that target nausea. So if one thing's not working, like if you've been nauseous, you've gone and told your doctor or your nurse about it, they've given you some medication for it, the medication's not working, make sure you go back and tell them so that they can try the plan B and the plan C and the plan D. And so that's really important. The other thing with nausea is if you're vomiting, don't let yourself get diarrhea. Don't let yourself get dehydrated. Make sure you're keeping your fluids up. If you can't tolerate fluids, again, on the blower to your treatment team. Don't put up with that. I was going to say something else about nausea. What was I going to say? Maybe I've just got vague as well. Yes, it's come back. Complementary alternative medicine can be, or at least complementary medicine can be really effective for nausea. So we know actually there's some evidence around things like hypnotherapy and acupuncture with nausea. So if you're on all of the available treatments and you're still, feeling queasy, it may be worthwhile looking at some of those options as well. Okay, I think, one more thing. Oh God, I'm really vague today. Even though I haven't called us Unicorn Foundation, I'm still, losing track of my thoughts, so apologies. The other thing that came up before this discussion today that people wanted me to talk about was peripheral neuropathy. Now, peripheral neuropathy, it's a big long word, and it really is talking about dysfunction in the nerves that can be caused by some chemotherapy. So the O in Folfox and Folfiri is oxaliplatin, and oxaliplatin is the prime candidate, although there are other carboplatin. Some of the other drugs can also cause peripheral neuropathy. So, and it's because they're called neurotoxic, so they actually damage the nerves. It's really important, so important, if you're starting to get that side effect, again, please tell your treatment team. It can be an important thing for us to be looking at your dosage of your treatment to see if we need to reduce the dose. Sometimes they'll swap out the oxaliplatin for a different drug. It's an important side effect for us to be monitoring and be really paying attention to, because it can be irreversible. Now, I have seen people who have had improvement over time with this, but I've also got, I've actually got a close friend who had her chemotherapy. She had Folfox for a different sort of cancer 10 years ago, but she still feels like it's for her, it's in her feet, and it's like walking in wet plastic bags, and it's really affected her balance. And she's also a nurse, and she's found that it's difficult now to do things like give injections because she's lost some dexterity in her fingers. So it can cause a sensation of numbness or tingling like pins and needles, but it can also sort of cause proprioceptive differences. So that's sort of not really getting a sense of where the tips of your fingers or where the ends of your feet are in relation to the rest of you. So it's a really important side effect. One thing I would say is that it's really different from the peripheral neuropathy that's caused by diabetes. So it's quite a separate issue. So I'm not going to go into diabetes today, but peripheral neuropathy is a problem that can happen for people with diabetes. It's not related to chemotherapy. It's a different issue altogether. So before I finish, I'm just looking at the time and thinking, yeah, well, here she goes again. She's talking and talking. But I did need to talk about safety and chemotherapy. When people come for chemotherapy in a day treatment centre where you're sitting down and having a drip, I feel like we emphasise this a lot. So we talk about things like all of your bodily fluids are actually made slightly toxic by the drugs that are in your system. So if you're on chemotherapy, it's usually up to about a week afterwards that you need to be careful. And that means when you're going to the toilet, making sure that you're containing the bodily fluids that are coming out of you, in terms of your urine and your bowels, but also your saliva, your sweat, vomit, and semen and vaginal fluids are also something that will become cytotoxic if you're on chemotherapy. And that's regardless of if you're on IV chemotherapy or if you're taking tablets or anything else. So pay really close attention to the instructions that are given to you about that. It's really important. We don't want to expose those around us to unnecessary levels of cytotoxic chemicals, because they're really useful for you if you've got a tumour, but especially if you're in contact with children or people who are of childbearing age, that can actually really stuff them around badly. So we need to protect those around us. Also with tablets, you need to be very careful of the storage of chemotherapy tablets. So they need to be very much kept outside of reach of children. It can do children a lot of damage indeed to have taken one of these tablets by accident thinking it's a lolly. With breaking the tablets out of the container, often you'll be told to wear gloves or to make sure you wash your hands really carefully afterwards. Please don't. I know it's really tricky because a lot of people are on chemo tablets for a really long time. It's easy to get complacent, but once again, these are toxic drugs and you need to treat them with respect and care. I'm just making sure. Oh, the other thing in regards to chemotherapy and safety, apart from checking the blood levels and things like that, the other thing just to bear in mind is that there are other drug interactions that can occur with chemotherapy, and also complementary medicines. So a lot of herbal treatments and vitamin supplements can actually really muck with the way that chemotherapy works. And a prime example of that's vitamin C. So it's not uncommon for people to have suggested to them to be supplementing vitamin C or even vitamin C infusions. But we know that's actually going to work directly against the action of chemotherapy, because vitamin C, the reason people are often taking it is to the perception of strengthening their body's DNA and stopping them being so susceptible to damage. But actually that's what we're wanting to do with chemotherapy. So if you're taking high dose vitamin C and chemotherapy, they're going to be having a good old tug of war inside your system, and it may well reduce the effectiveness of your chemo. So please always check with your doctor. Some doctors will say, oh, I don't really care what you're taking, but then please make sure with your pharmacist. Your pharmacists are actually such a fantastic resource. They're a font of knowledge in terms of those drug interactions, and they've got all of the information at their fingertips. So talk with your pharmacist about if you're taking any complementary herbal or vitamin or that sort of stuff alongside chemotherapy, because it may well be really, really crucial to the effectiveness of that treatment. Okay. I'm just going to have a quick look through the comments and see if there's anything else that I should be responding to. One thing, while I'm doing that, I'm going to try and talk and read at the same time, which may or may not be possible. But the Cancer Council have a fantastic booklet. I know I'm plugging the Cancer Council resources all the time, but it's because they're really good. And I will put a link to the chemotherapy booklet from the Cancer Council in the notes as well. So I think that's where I'll leave it with chemo today. There may well be more questions that come out of this, so I'll be hopping into the Facebook space afterwards and seeing if there's anything more that I can help you with. For individual advice, once again, talk to your doctor, talk to your treatment team, or you can contact me. And this is probably leads me to the next bit of what I wanted to talk about today, which is just about getting in touch with me as the net nurse for Neuroendocrine Cancer Australia. It's really important that those messages come through either via email. So my email address is netnurse@neuroendocrine.org.au, or via the net nurse line. And I'm not going to try and remember the phone number off the top of my head, but I'll put it in the notes. I've just had lots of Facebook messages this week, and if you've sent me a Facebook message with a question in it about your care or your treatment, you'll get a little bit of an automated response saying, I'm really sorry that I can't answer net-related questions via Facebook Messenger. And there's a couple of really good reasons for that. There's some legal issues with us providing some, medical advice and information via social media, but also just in terms of me keeping track of everybody and making sure I've answered all of the inquiries in the order that they've come. It just it gets a little bit too complicated for me to keep track of Facebook messages. So if you've got an issue with something to do with the Facebook groups or the Facebook page, then sure, that's sometimes there will be messages from me and to and from me regarding that in terms of Facebook Messenger. But if you need to talk to me about your individual medical situation, email please is great, and I can get back to you within the next couple of days. The other thing I just wanted to do while I'm on housekeeping, our Facebook group has grown quite a lot over the last few weeks. So welcome to people who are watching for the first time. It's really fantastic to see so many new faces and people hopping in and getting that really crucial support. If you are inviting someone into the group, which you can do, so the group is for people who are directly affected by NETs, either as a person who's got a tumour themselves or they're a carer. So if you're keen on raising awareness of neuroendocrine cancer more generally, our Facebook page is a really good place to direct people, as well as our e-newsletter, and I'll make sure I've got links to both of those things in the notes. If you are inviting someone who you would consider a carer, such as a family member, it's really great if you can send a message or an email to me or one of the other group administrators, and I'll put their details in the notes as well, just so we know, because it can actually be really easy to do it by accident, and we always check, because that person may not be up for the content that's in the group. So if you invite someone, really fantastic if you can just confirm, let us know that that's a thought out decision and that you're keen to do that, and that's absolutely fine. The other thing is, if you're watching this on YouTube and you're keen to join the group, we'll make sure the notes to the group are in the note. The link to join the group is in the notes. There are importantly 3 questions that we will be asking you to answer before you join. I know when I'm on my phone, sometimes they flash up and my screen's gone. They sort of feel like they've gone before I've even had a chance to really look at them. But we won't put you into the group unless you've answered the questions. For people who click join the group and they haven't quite seen the questions, we'll send you a private message. But Facebook in all its wisdom, means that Facebook messages from people who aren't your friend, it can be really tricky to see. So if you're clicking to join the group and you haven't found out that you're in the group and you're just hearing crickets, check your Facebook messages, your message requests, because there may well be a message from one of our team, our moderation team, to say, hey, did you forget to answer did you see the questions? These are what they are. And once we've got the answer to those questions, we can put you through. Just for your information, the Facebook group is for people just in Australia. So if you're international, I can actually help you link in with local supports, but this Facebook group that I'm talking about at the moment is just for people in Australia, as well as a few Kiwis who are always welcome here. So just really brief housekeeping. I'm really, really thrilled to let you know that we have 2 new members of our Consumer Advisory Group who we've just confirmed this week. So a big welcome to Philippa, who is joining our Consumer Advisory Group from Tasmania. And Philippa is a carer of someone with cancer, so we're really excited to introduce Philippa to you and to have her as part of that team. The other person that we're welcoming onto the Consumer Advisory Group, her name is Alison, and she's from South Australia and she's rural. So these voices of people who are rural, people who are carers, people who live who have various circumstances, they are all really crucial to the work of this group. And I'm so pleased to say now that our Consumer Advisory Group is at its full quota, so that's exciting for us as we look to the next couple of years with this term of group members and all of the really important work that we're going to be doing together. So welcome to Philippa and Alison, and we're so appreciative to you guys and absolutely everybody who does this fantastic voluntary work for our organisation that wouldn't be able to exist if it wasn't for our volunteers. So I've also talked about our volunteer Facebook moderators today. These people are doing stuff, spending time every day helping to take care of people with neuroendocrine cancers in Australia. So deep gratitude. Just a heads up because it's tomorrow, it will be 1 month until World Net Day, until the Neuroendocrine Cancer Day worldwide. Here in Australia, we are going to be running a very special event online, unsurprisingly given COVID, but it's a State of the Nation online forum, and it's going to be on the 10th of November. There's going to be details on our website and lots more promotion coming really soon, but I just wanted to give you a heads up to look out for that. You'll be able to join in on the day and watch the presentations from doctors and experts all around Australia. You'll be able to add in your questions and we'll attempt to answer those during the session as well. And of course we'll be recording that, so if you can't make it on the day, you'll be able to catch up with that at a later stage. So just keep your eye out for that. More stuff coming in this month's e-newsletter and on our Facebook feed and all the usual channels. The other thing I really, really am excited to plug is that next week is National Carers Week. So this is a week where we really reflect and think about the role of carers in the lives of people who have something like neuroendocrine tumours, and knowing that that's a significantly different situation from having a tumour yourself, but complex and challenging, and really important to acknowledge and support. So next week, during time to finish, okay. Next week during National Carers Week, we're actually very, very thrilled to be able to follow up from our interview with Mark Camilleri last week, which I know that everybody really loved because we got hundreds of views on the video, which was exciting. But I know that lots of you really enjoyed hearing from Mark Camilleri last week. Next week we're actually incredibly privileged to hear from Sylvie, Mark's wife, who has agreed very generously to come along and share some of her story and to have a chat with us about what it's like to be a carer. So I'm really very much looking forward to that. At the same time, 1:00 p.m. Eastern Daylight Time in Australia, either live via our Facebook private discussion group or later on via our YouTube channel. So thank you everybody for joining me. I am going to leave it there because once again I have talked for way too long. It's been lovely to spend this time with you. Don't forget to reach out and support each other over the weekend and during the week. I love the way our Facebook group has such an amazing combination of people who come in and share their really good news. You know, so we had a couple of people just in this last week who have had surgery, and their tumours have been taken out, and we celebrate that. We celebrate when people get really good PET scan results and their tumours have shrunk. But we also gather around, and I think we're really great at supporting people when they're doing it tough, when tumours might be growing, they might have got bad news. So the group is for everybody, regardless of whether you're in a good place or whether you're struggling. We have everything from unicorn jokes right through to conversations about really deep and serious things. So I love that in our group, and so I'm looking forward to seeing those conversations continue. I will see you all next week with Sylvia. So yeah, take care everybody, and I'll look forward to talking soon.